talking about some diverticular. All right. Can everyone see my screen there?
Yes, sir.
Yes. Yeah.
Yep, that's making sense. Good. All right. We're going to talk about diverticular disease today. It's something that I was having a talk to Sonal about this afternoon. Something that we see a lot over here in Australia, and I think Sonal was talking and describing that this is increasing in prevalence in Fiji as well. But hopefully we can cover some of the main pertinent topics of diverticular disease and discuss. And credit goes to Ben Scott, who's one of our registrars here, who made this presentation. We're going to start with a case presentation to start with. So this is a 60-year-old lady who presented to the emergency department with some acute abdominal pain. She was unwell for 3 or 4 days. She described some fevers at home, off her food, background of rheumatoid arthritis and some hypertension, but otherwise pretty fit and well. She had some a tender abdomen with some localized peritonism in the left iliac fossa. She was febrile and tachycardic on presentation. We're going to start with Linda to start with. Can you talk me through how you would initially assess and manage this patient?
Okay. So summary of this case is a 60-year-old female presenting to the emergency department with acute abdominal pain, peritonism in the left lower quadrant, with the vital sign. She's tachycardic and also febrile. So initial assessment of this case is most likely something infective that is going on in her abdomen. So I would be thinking whether it's colitis, whether it is also diverticulitis, probably complicated, probably developed a diverticular abscess that could have ruptured. I'm also thinking of what else? I could be also be thinking of something gynecological.
Yep. All right. And how would you approach? You go to see this patient in the emergency department. How would you approach their initial workup and management?
Okay, so with this lady, she sounds like a very sick lady. So I would see her in the emergency department according to the CRISP algorithm.
Yep.
So I would assess her airway,
yep.
Breathing, put on a mask.
So you see her airway's fine, breathing. Yep.
Yeah, give her maximum O2,
yep.
monitor her saturation.
Yeah.
For circulation, I think I would be worried about circulation with the tachycardia there. Yep. So I would put in 2 IV ball cannulas, yep. Collect full blood count. I would want to know her white cell count,
yes.
Hemoglobin status, and platelet. These things I'm already thinking of whether I should optimize her for OT, so I would need those baseline bloods.
Yes.
Urea, also electrolytes is important in terms of her age, with the symptoms she has and the yes. kidney functions. Yes. And I would start her on IV fluid resuscitation, just give her a bolus.
What would you give her? How much?
I would give 1 liter of normal saline.
Yep.
And then I would also put in a catheter in just to monitor her urine output and assess whether she is a rapid responder or a transient responder.
Okay, sounds good. Okay, so she responds, her tachycardia settles a little bit, and she actually doesn't look that bad from the end of the bed. What are you going to do next?
Okay, next I would try and order some investigations to see what is happening with her abdomen. So I would order a abdominal X-ray supine, and I would also order for a ultrasound scan just to look at her abdo-pelvis.
Okay. So there's no ultrasound that's available, and the abdo X-ray shows some non-specific bowel gas pattern, but there's no evidence of a mechanical bowel obstruction. Where would you go from there?
Okay, so I forgot to mention I would start her on antibiotics also, just to give her a broad spectrum.
What would you give her?
I would give her.
Sorry. First question is what type of bacteria would you be concerned about?
In this case, I would be worried about. Well, I would think of everything of gram-positive, gram-negative, and also for anaerobes for her. So just since we don't know what's the actual cause of the organism, I'll just cover for everything.
Yeah, I think in particular, it's going to be the gram-negatives and your anaerobes that you're going to be concerned about. Would be the most likely cause. As you said, she looks like she's got intra-abdominal sepsis, so it's really the gram-negative and anaerobes that we're going to want to cover. What antibiotics would you give her?
So I would go for ceftriaxone and also IV metronidazole.
Sounds good. All right. So you give it that as well.
Just one thing, Henry. Anna,
Yep.
would you really order an ultrasound on this patient? What's your indication for the ultrasound?
So because it's a female, I just want to rule out for especially for the gynae pathology part, if it helps.
Fair enough. Okay, so that's where you're trying to rule out in a 60-year-old woman.
What type of gynae pathology could there be, Linda?
It wouldn't fit with her age, but since she's still a lady, I would rule out any tubal ovarian abscess. It still can happen, but rarely.
Yep.
What else am I? A ruptured cyst, or she might be having a huge fibroid.
Cyst in a 60-year-old. I think, Linda, although you're thinking widely and differentially, I'm just giving Henry a context of this. I don't think you'll be ordering an ultrasound in PG.
Okay.
That's not a common thing to be looking for in a 60-year-old woman, to be looking for ovarian abscess or that, unless your people's practices have changed. I don't think that'll be your first line investigation on that one.
All right.
Luckily, the sonographer was out of town anyway, Linda, so they couldn't do it anyway. What are you going to do next? Where are you going to go to? What are you going to do? You got that abdo X-ray. What are you going to do next?
So next investigation, I would assess the patient again, but the other thing I'm thinking of is to do a CT scan abdo-pelvis with a contrast if her creatinine functions are okay. Yeah,
okay. All right. I've pestered, well done, Linda. I've pestered you enough. Anna, when you're requesting the CT scan, what type of, Linda correctly mentioned you'd want contrast. What type of contrast would you request? If the radiographer specifically asked, what type of phase of contrast would you want?
I'm not too sure what phase of contrast would you for this one.
Yeah. Does anyone else know what phase of contrast, or what's the standard? So we normally give intravenous contrast. Does anyone know what would be the standard phase of contrast that we would give?
They usually come in the triple phase contrast.
Triple phase, we can normally, again, I may be corrected, Sonal by Fiji, but normally here we would give a portal venous phase contrast for our standard CT scan of our abdomen and pelvis. So the different phases, and alluding to what you were talking about, someone mentioned then, so triple phase CT would be looking for an arterial, portal venous, and a delayed phase. But normally in workup, a CT scan for intra-abdominal sepsis, we would give a CT scan with portal venous phase contrast, and it can be done plus or minus with or without oral contrast as well.
Standard portal venous is what they'll order in Fiji too.
Yep. Okay. So portal venous phase contrast, which I think is important to know. So I think, as Linda covered correctly, so this patient was assessed with the CRIS protocol, ABCDE. They had some IV fluids. They were responsive to that. These are the results that we've already covered. And this is the CT scan that we can see. Anna, this is the CT scan that's up. Can you talk me through, again, we've just got a single slice here, but can you talk me through the findings on the CT scan and talk me through what you're thinking from here?
Okay, so this is a pelvic scan, a single slice we're looking at. There's some thickening on the left lower regions. You can see some dilated loops of bowel there. Extraluminal gas, I can't really see. But there's definitely some signs of collapsed bowel and dilated bowels on top, likely in the sigmoid region.
I'm just going to give you these,
or lower down.
These views here as well. What do you think?
Okay.
What do you think? This is some more views. What do you think?
Could be some fat stranding going along the sigmoidal region. Are those extraluminal gas you see there, or?
Yep. Where do you think that extraluminal gas is if you were going to describe this CT scan?
It's more on the mid-centered regions.
Yep. Which part of the abdominal cavity do you think that it will be?
Maybe perhaps large bowel, or?
Yeah, so in particular, you can see these locules, these extraluminal gas, as you correctly said, and you can see this here, which is coming. What structure do you think that is there, Anna?
Aorta, or?
Yep. What structure is that going to be there?
Archiperitoneal region. Oh.
Yeah. What structure is going to be to the immediately to the right of the aorta?
See.
Source muscle.
Inferior vena cava.
Yeah, correct. Yep, good. So we've got aorta and IVC here. And you can see this large amount of free gas that's surrounding these structures. And having a look back here on our axial slices, again, you can see a large amount of free gas. So this is retroperitoneal free gas. Okay, so this is someone with what looks like, back on this previous CT slice, some thickened and inflamed sigmoid colon. And then we've got a CT scan with a large amount of retroperitoneal free gas. I'll move on to Kanong. Kanong, can you talk me through what you think is going on in this case, or what's the possibilities with what's going on?
I was thinking of inflammation, infection around the here.
Yeah, so we've got someone with inflamed sigmoid colon, and we've got retroperitoneal free gas. What do you think? What do you think? What's the pathology? What's the pathogenesis of what's going on here?
Retroperitoneal gas. There's the peritonitis going on.
Peritonitis. Yeah, more specific. More specific. What do you think? What do you think's happening?
Not sure.
Anyone else got some ideas about what they think is happening?
Perforation of the retroperitoneal part of the colon. Good.
Yep. Good. So it looks like we've got a retroperitoneal sigmoid perforation. Yes. So Leslie, talk to me about, so obviously just broadly speaking, so we've got free gas, something's perforated here. The only other possibility is that it's a gas forming organism, right? Very uncommon. You've got free gas inside someone's abdomen. We've got a hollow viscous perforation. And as we probably know, most perforations will occur intra-abdominally, intraperitoneally, and you'll end up with free peritoneal gas. Yes. But if you've got, obviously there's parts of the colon that are retroperitoneal, and so if that colon perforates backwards or into the retroperitoneum instead of into the peritoneal cavity, then you're going to end up with a retroperitoneal free gas and retroperitoneal perforation. So Leslie, what are the, in terms of, you're right, that's what's happened in this case. what's the actual underlying pathology that can account for this?
Yes, so for diverticulosis, it occurs in the mesenteric part of the colon,
Yep. So
lateral to the tinea.
Perforated diverticular disease, yep, which
Yes.
will normally be perforated diverticulitis. What are the other possibilities?
So I would put it through my pathological sieve. Diverticulitis would be inflammatory. I would think of malignancy. Yep. I would think of foreign body that has been trauma.
Malignancy, the other big one. So perforated sigmoid colon cancer.
Yes.
Yep.
Or traumatic or infective cause that might perforate the colon.
Yeah. So yeah, but yeah, diverticulitis and malignancy, they're going to be the two big ones. Hey, there's going to be a whole range of other things and foreign bodies and trauma and things like that. They're all going to be much rarer, but it's going to be either cancer or diverticulitis. They're the two most common causes. So Lacey, what would you do with this patient?
Yes, so obviously she's in, her vitals are responding to resuscitation.
She's got a heart rate of, her heart rate's 110 and she's got another fever of 38.8.
Yes, so I have my antibiotics on board. I would be planning to assess this using my Hinchey classification of diverticulitis. And it seems like there's a perforation of the diverticular abscess that has extended to the retroperitoneal cavity. So I would be leaning more towards a operative approach. Yep.
So what are you going to do?
So I would so from the sigmoid colon, so I would be planning for a midline laparotomy with on-the-table colonoscope to identify exactly the lesion and then plan to do a resection of the affected bowel.
Yeah. And so we think this is, what operation do you think you're going to do?
Left hemicolectomy, yes, with a stoma. Seeing as there's a lot of infection going on in there, I wouldn't do an anastomosis.
Yeah, nice. So you're going to do a Hartmann's procedure. Hey,
yes,
you're going to,
yes.
We're planning on doing a sigmoid colectomy here and making an end colostomy.
Yes.
Would you normally do an on-table colonoscopy?
I would be preparing for it, just in case that I may need to do one before operating, just to locate exactly where the pathology is.
Yeah, it's always an option. It's something that we wouldn't, I wouldn't normally do. I think most of the time in this situation, you're going to open up the patient, as you said, midline laparotomy, but you're going to clearly see what the disease bit of bowel is. Hey, there's going to be fibrin. It's going to be, you're going to identify that operatively. Colonoscopy is always an option to make sure there's nothing going on, but I think that's unlikely. I think what the patient needs here is a laparotomy, identify where the inflamed bowel is, and then create a stoma from there.
Yes. Oh, yeah.
Yep. So Hartmann's procedure. So that's what we went on to do. We went on to do a Hartmann's procedure. We found a perforated sigmoid diverticulitis with a retroperitoneal perforation, as you spoke about. We excised the sigmoid colon. And then the interesting case in here, there was a lot of retroperitoneal contamination. It had perforated behind the sigmoid, behind the small bowel mesentery and up into the retroperitoneum. And we did some debridement, washout, left a couple of big drains. And as you correctly said, Salisi, we made an end colostomy and closed the patient up, and they did very well. And the histopathology confirmed perforated sigmoid diverticulitis. Will allow them to recover for 3 to 6 months. She's a relatively well lady, and then we'll work her up towards her reversal of a Hartmann. So I thought that was just an interesting case to get things started. So we're going to go on and talk about, first of all, we'll talk about diverticulosis, then we're going to talk about diverticulitis, and then cover some epidemiology and natural history. Paneet, can you define diverticulosis for me, please?
So diverticulosis is just just the presence of diverticula. Needless to say that it is not symptomatic. It's just presence of the diverticula.
Yep. And can you tell me about what is the pathogenesis of diverticular disease? Why did diverticulum form?
Could be due to the aging of the bowel that usually becomes weakened over time, and could be also due to inflammation that, or the bacterial overgrowth causing inflammation and outpouchings. I'm not too sure about this exactly.
Yeah. So, but yes, so you certainly, yeah, you're on the right track. So as people get older, do you know what I mean, the prevalence or of diverticular disease increases, but there's a specific part of the bowel where diverticulum form. Does anyone know where in the bowel which part of the bowel wall they form and why?
It's mainly it's a false diverticular, so it only involves the mucosa and the submucosa, which protrudes through the muscularis propria.
Yeah, and so whereabouts, Linda? Where does it form? Like you talk about, yes, they are false diverticulum, but whereabouts? How do they form?
Is it at the junction of the triangular muscle sheaths and where the blood supply enters the bowel wall? That's exactly where they.
Yeah, exactly, Panet. So yeah, they form where the vasa recti, so the blood vessel, penetrates the muscularis propria, and what that causes is therefore a potential area of weakness. And then diverticulum form intraluminal pressure results in subsequent herniation of the mucosa, and that is what leads to the formation of a diverticulum. Okay, so it's a potential area of weakness at the vasa recta where they penetrate through the muscularis propria. Okay, just something very simple but always good. Sajnil, tell me about what are the layers of the bowel wall?
Mucosa, submucosa, muscularis layer, and the serosa.
Yes, and we talked about the diverticular disease of the colon is a false diverticulum. Can you define what a true diverticulum is, and can you give me an example of that, please?
Yeah, so true diverticulum would are usually congenital. They involve all the layers of the bowel from mucosa to serosa. Good example is Meckel's.
Yep, perfect. Sounds good. Okay. So we'll go on. So diverticular disease is a condition where diverticulum pockets of bulge form in the large bowel. It's related to a low fiber diet and high colonic pressures, especially in the sigmoid colon. Now, who have we got? Oh, sorry. Who have we got online there? Who else have we got there? Sajnil, can you tell me about where is diverticular disease most common? Which position in the colon?
It's most common in the sigmoid colon.
Yep. Why is that?
Yeah, so the sigmoid colon is the one that has a lot of redundant bowel. So with the constipation and high pressures, and it has a wide diameter, so most of the pressures are directed radially. I think that's why.
Good, certainly good shot. You're on the right line, but I'm going to say no, that is not the reason. Does anyone else know why is sigmoid colon the most likely place?
Yes, so a stool on the left side is more hard and solid compared to the right side. Another one would be it's more free to move, as Sajnil was mentioning, so that would have more problematic peristalsis or segmental peristalsis that would also contribute. And the other one is that the lumen is a bit narrower compared to the other bowel.
Yes.
Thus it will, yeah.
I like the last, I don't think it has anything to do with the redundancy or movement or anything like that. It's the caliber. So the narrowest part of the bowel is the sigmoid colon. So I think that's the answer that I think of, and I think this is the answer to the question, is that it's the narrowest part of the bowel. And there's something called Laplace's law. I'm not sure if anyone's heard of.
Law of Laplace.
The relationship of intraluminal pressure to tension on the wall to the diameter of the structure, and it describes the relationship. And essentially, the narrower the diameter of the tube, the greater the tension there will be on the wall. So at the narrowest part of the bowel, which is in the sigmoid colon, this will relate to, as the colonic contents pass through, this will create the most tension on the wall. And it's this tension on the wall that we spoke about that creates the increased tension, which will therefore result in the herniation of the mucosa at that potential area of weakness next to the blood vessel, which will result in the formation of diverticulum. Does that make sense?
Yes, yeah.
Yep. And Laplace's law is another, probably the other thing that we use to describe it or think about is, I'm going to ask someone else who hasn't asked, Tavita. Have we got Tavita online? Maybe not. Have we got Uriam online?
Yes, sir.
Uriam, hello. Question for you. In a obstructing sigmoid colon cancer, where is the most likely part of the bowel that will become ischemic? So in an obstructed sigmoid cancer, so patient comes in with a large bowel obstruction, which part of their colon is the most likely part of their colon that will become ischemic?
I'm not sure.
Anyone else that can help out? Where's the place in a large bowel obstruction? Where's that most likely to become ischemic?
Cecum.
Cecum. Yep. Who said that?
Yes. So so according to the law of Laplace, the greatest area that would really, closed loop obstruction would be the greatest area that requires the least amount of pressure to distend would be the cecum. So that area would likely be ischemic than perforate, according to the law of Laplace.
Good, perfect, spot on. Yep, spot on. So that's how Laplace's law will also help to describe the phenomenon of why the cecum is the largest part of the cecum has the largest diameter within the colon, as why that will be most likely to be the first place to become ischemic in the presence of distal obstruction. All right. Now we'll keep moving. We'll move on to diverticulitis. Sela, welcome. Can you tell us about what is diverticulitis and what causes diverticulitis?
Hello again, everyone. The diverticulitis, this is there on the presentation, inflammation or infection of the diverticulum.
Yep.
What causes it is when there's an obstruction to the pouch itself, and then this causes necrosis and ischemia, which then causes the infection.
Yeah, so I think you're on the right lines, Sela, but I'm going to say that's not the most common cause. That's not how you normally get diverticulitis. So I think that's correct when we talk about appendicitis. So appendicitis is caused by luminal obstruction, which is normally by a fecalith, but can also be by lymphadenopathy, or it can also be by a tumor. But that's not the most common cause of diverticulitis. Who knows what is the most common cause of diverticulitis?
Is it just microperforations?
Perfect, spot on. Who said that?
Yes, Salesi, yeah.
Salesi, yes, yeah. So yes, you're spot on. So it's microperforation. That is the most common cause of what diverticulitis. I think we spoke about this with Professor Guest a few weeks ago. I think sometimes you can get a fecalith that lodges in and can cause some diverticulitis, but the most common cause is microperforation. You've got a very thin bit of bowel. It's a false diverticulum. It only contains mucosa, and as a result of that, that can get a hole in it. And as a result of that, it causes can cause diverticulitis. Yep. So I think one important thing to remember. The incidence of diverticulosis by age, I think we mentioned this earlier on. So obviously this is a condition that increases in prevalence with age. So this, again, these are figures from the Western world with our low fiber, fatty, unhealthy diets over in Australia. And as you can see that the prevalence increases by age. I remember the rough figures in Australia, as we say about 50% of people at the age of 50 or 80% of people at the age of 80 have diverticular disease, okay? Again, in Western populations where it's predominantly left-sided disease, where in Asian populations it's more likely to be a right-sided disease. In terms of the natural history of diverticulitis, not everybody with diverticulitis will go on to have symptomatic, not everyone with diverticular disease will have symptomatic disease. We say about 20%, so 1 in 5 people will be symptomatic, and about 5% of people with diverticular disease will have an episode of diverticulitis or significant bleeding. We've covered over what's the cause of diverticulum developing, where they tend to occur in relation to the blood vessels. We talked about them being a false diverticulum occurring next to the vasa recti. All right. We covered this here, so just to recap and go over this, so increased luminal pressure causes herniation in the mucosa and submucosa through points of weakness in the colonic wall where the vasa recti penetrate the circular muscle. Due to high pressure in the sigmoid colon, some weakening in the colonic wall, and that increased pressure. I'd like to ask someone else a question. Uriam, do you get diverticulum that form in the rectum?
Diverticulum that form in the rectum.
Sorry, say that again. I just missed it.
I didn't get your question.
Oh, do you get diverticulum that form in the rectum?
I think so, yeah, because diverticulum can form around the intestinal tract.
Yeah. Have you ever seen?
Hello.
Have you ever seen diverticulum in the rectum?
Hello.
Room, have you ever seen diverticulum in the rectum?
No, I haven't.
Yep. Do you know what I mean? You never say never, but do you know what I mean? We often see it. Often we see in Australia lots of diverticular disease in the sigmoid colon and in other parts of the colon, but do you know what I mean? It's very, very rare that you get diverticular disease that develops in the rectum itself. Why do you think that is? Why do they occur everywhere else, but why don't they occur in the rectum? Any ideas? Can anyone else help out? Anna, what do you think?
It's probably because of the facial planes that surround it and the support it gets from those.
Yeah. Yeah, I think you're on the right line. Pane, talk to me about how do the layers of the rectum differ to other parts of the colon? Any ideas? Or tell me about, we'll go back to, tell me about how do you tell when the sigmoid colon turns into the rectum? What do you use as landmarks to identify the rectosigmoid junction? When you've got someone in operation and you want to identify what's going on.
Tinea coli.
Hold on, I just missed that. Sila, tell us about how would you identify the rectosigmoid junction?
You usually follow the tinea coli, I think.
Yep. And so what happens at the rectosigmoid junction with the tinea coli?
Sort of comes together.
Yeah, yep. Spot on, 100%, they converge. So what that represents the tinea coli represent those longitudinal muscles of the sigmoid colon. And in the sigmoid colon, you've got obviously 3 tinea coli, which run down the sigmoid colon, and they then converge on top of the rectum, okay? And I think it's probably a combination of a number of different things. This is what we talked about with Professor Guest in a few weeks ago. It's probably a combination of a few different things, but one of the reasons is you get that extra layer of muscle in the rectum. So where you get the tinea coli that converge at the rectosigmoid junction, they create a continuous longitudinal muscle layer at the rectum, which again strengthens that muscle wall and decreases the risk of herniation of the mucosa. The other thing is that the rectum is also, the caliber of the rectum, the diameter of the rectum also increases. It becomes more of a low pressure zone to create that, to be able to dilate out, to create as a storage for stool, and probably also results to increased diameter, which results in less wall tension and therefore less risk of herniation of the mucosa. So I think that overall the thing is very, very unlikely. We don't see diverticular disease form in the rectum. We see it form in other parts of the colon. Okay. In terms of Sila, what apart from the convergence of the tinea coli, what are the other landmarks that you use to identify the rectosigmoid junction? We've lost Sila. Anna, tell me about what are the other landmarks that we use to identify the rectosigmoid junction?
Use your lumbar.
Sacral promontory.
Yeah.
Spot on, yes. What else? One more. So I think it's the third one I think about is the loss of the sigmoid mesentery. Okay, so your sigmoid colon's on a mesentery. It lifts up, whereas the rectum has no mesentery. So I think they're the three key landmarks that we think about. Okay. Who have we got? Linda. Obviously, diverticulitis is one of the complications of diverticular disease. What are the other complications apart from diverticulitis of diverticular disease? What else can happen?
So complications are localized. They can develop, apart from diverticulitis, they can develop a pericolic abscess that's confined to the mesocolon.
Yes.
They can also develop pelvic abscess, which then can progress to peritonitis, where you have the rupture of that abscess, or you can have fecal peritonitis.
Yep. So I think they're all complications of diverticulitis, which you're very right about. But apart from inflammation of the actual diverticulum, what else can complicate it?
The other things we can look at is patient factors. If they have got any, is that the question?
No.
Okay.
No. Apart from diverticulitis, what are the other things that can go wrong, or what are the other complications of a diverticulum?
The fistula.
Bleeding. Yeah.
Bleeding. Yes.
Yeah.
Spot on. Yep. So bleeding is the other complication. Who said that? Was that Uriam?
Yeah.
Yep. Uriam, why do you get bleeding? Why do diverticulum bleed?
It's bleed because it's associated with the blood vessels that bulging out with the diverticular disease.
Yes.
That's
Yeah, spot on. Yeah, because we know from the pathogenesis that the diverticulum forms next to the where the blood vessel penetrates the muscle wall. So therefore, that blood vessel is, in close proximity, and it can erode into the blood vessel, and therefore you can end up with bleeding. Yep, spot on. Which we've just covered here. So again, we talked about what causes diverticulitis. So we described that as microperforation, and diverticular bleeding, as we spoke about. The penetrating branches of the vasa recta end up draped over the diverticulum, leaving them exposed to injury, which results in recurrent inflammation of the vessel and can result in some hemorrhage. So how does what type of bleeding does diverticular bleeding normally present as? Sajnil, what's the typical presentation of diverticular bleeding?
Usually they present acutely with fresh PR bleeding.
Yes.
And a lot of times they can also bleed very massively as well. They can have massive PR bleeding.
Yep, good. I think you're spot on there. You normally get this very large, acute, significant bleed that will normally resolve. It's not it doesn't cause chronic small volume bleeding like hemorrhoids causes. It's normally a large, acute, significant perectal bleed. Correct, spot on. So in terms of, we started talking about this, we've obviously talked about infection as a complication of diverticulitis, otherwise bleeding as well. Other things, I think I heard someone mention you can get fistula that can occur, and then you can also get strictures, diverticular strictures. Where's the most likely or common place for diverticular disease to fistulate to?
Colovesical fistula.
Yeah, to the bladder. Yep, spot on.
Later.
All right. So we're going to go, next question is, so we've obviously got diverticulitis, and then you can, that's obviously classified into uncomplicated and complicated disease. So uncomplicated disease is inflammation without macroscopic evidence of perforation or abscess formation. Can someone talk to me through how is diverticulitis classified? Complicated diverticulitis classified. Does anyone know a classification for this?
It's, I just know the CT classification, the radiological classification for diverticulitis, using the Hinchey classification.
Yeah, nice. Can you talk me through what is the Hinchey classification and Celesi, and how do you classify that?
So 1 would be very contained locally around the bowel itself, and 4 would be fecal peritonitis.
Yep. And what's 2 and 3?
Between that would be, I think 2 might be just a local abscess formation, and 3 might be local peritonitis. I'm not too sure.
No, that's fine. We've got it up here. Hold on, we'll just go through it here. So this is the Hinchey classification. So this is Hinchey. I don't know where Hinchey was from or anything about Hinchey, but he obviously came up with this classification. He's these are the 4 things, and this is really, and this is I think we talked about, and we often apply it, Celesi, to a radiological classification, but it's actually based on operative findings, because there's no way of telling the difference between a purulent or feculent peritonitis on a CT scan. That's operative findings wise, but certainly we extend that classification to radiological interpretation of someone's diverticular disease. So this is the different types of things. So a 1A is inflammation or phlegmon without an abscess. 1B is a pericolic abscess, where 2 is a distant walled off abscess. So either in the root of the mesentery or in the pelvis is the most common thing that we find. Hinchey 3 is purulent peritonitis from perforation or abscess, whereas 4 is feculent peritonitis, so feces within the abdomen. All right. Now, in terms of, we'll go back, and these are some images, intraoperative images of the case. How would you, Paneet, how would you classify, or what classification based on this scan would you give the patient? So this is the patient we talked about at the start of this case presentation, back to the same CT scan. We've gone over the Hinchey classification. How would you classify this disease?
There's an obvious guess, and so perforation is there. So I'll just classify it as fecal peritonitis.
Yeah, fecal or purulent. So it's either a Hinchey 3 or 4.
4, yeah, 3 or 4.
3 or 4. Again, you can't tell based on this. You're probably right. It's probably fecal and peritonitis, but yeah, it's either a Hinchey classification 3 or 4. This is very difficult to see what we found here, but this is a finding of our laparotomy here, and we can see the sigmoid colon here, which has had the retroperitoneal perforation. This is what we found at the time of our operation. So I'll just, this is the end of our mid-sigmoid colon here that we've resected. This is our rectal stump looking down into the pelvis of the patient. And what you can see here is, you can see some fibrin and tissue where the tumour perforated retroperitoneally and was tracking up towards the head of the patient, which we needed to debride and wash out. Okay. This is again a classification system that looks like and discusses the different management options for a patient with different forms of diverticulitis. Again, the specifics are not as important here, but I think it covers some good general principles about how we approach and how we deal with patients with diverticulitis. So uncomplicated diverticulitis, we can either treat with inpatient or outpatient antibiotics. What factors would you use Panit to determine if someone is appropriate for outpatient oral antibiotics versus whether or not they need a course of inpatient intravenous antibiotics?
So this patient factors and patient's clinical presentation would be the main thing that I look at. If the patient is clinically not septic, they just have pain, and vital parameters are in normal ranges, and they don't have any other comorbidities such as diabetes or any other problems, and especially if they are young as well. So these are the patients I would try to treat them orally as an outpatient.
Perfect, spot on. Whereas patients who are, again, have got any form of immunosuppression, who are, elderly patients, whether or not they've got type 2 diabetes, or whether or not they're systemically unwell or got peritonism I'm worried about, need to come in for intravenous antibiotics. Yep. So that's kind of uncomplicated. Then we talk about diverticulitis with an abscess. So this will be either a Hinchey stage 1B or 2. How would you, in Fiji, do you have access to interventional radiology to perform a percutaneous drain?
No.
No, okay. That is, obviously, we have relatively good access here to interventional radiology where they can percutaneously drain. How we would normally manage it in Australia would be based on the size of the abscess. So an abscess that's less than 3 or 4 centimetres is the cutoff that we normally use. Then we manage with antibiotics alone. But for an abscess greater than 4 centimetres, then we would proceed with percutaneous drainage along with intravenous antibiotics. Okay. Then we move on to diverticulitis with peritonitis. So either Hinchey stage 3 or 4. Again, as we discussed about, following on from the case we were reviewing, the management for this is normally a laparotomy and resection. Let's have a look at, obviously, Tavita, can you talk to me about, so obviously you go in and you find perforated diverticulitis. What are your options for the operations that you can perform? Perforated sigmoid diverticulitis, what operations can you perform?
Bula, everyone. I think if this, depending from the type, and I know that most of the time that we operate on the stage 3 and stage 4, so it's either the patient is peritonitis. I'll take into account the emergency operation and also the comorbidity of the patient and the age of the patient.
Yes.
So with comorbidity and the old peoples and the high-risk patient emergency, I'll just go for a Hartmann procedure. So in that way that we can save the patient and we come back later when the patient is stable and we can reverse the Hartmann.
Yes.
If it's someone it's young and the comorbid, there's no comorbidity, it's not an emergency and you have everything with you, you can try then, if it's not soil, it's not fecal peritonitis, if you can control, then you can do a anastomosis and can try to pull up a ileostomy. That's my option. However, in my setting, I'll just go for Hartmann procedure and come back later.
Perfect answer. Yep, spot on. So again, that's what we would normally do. Most of the time, we'd end up doing a Hartmann's procedure, but I think as you very correctly said, that in young, healthy patients who are relatively stable, who don't have a large degree of contamination, you can consider a primary anastomosis with or without a loop ileostomy on top of that. Following up and continuing on from our case presentation, our patient spent 3 days in ICU, they had a week stay in hospital, and she went home relatively well. Just want to talk through some different cases here. So next case, I'm going to ask, who have we got? Niraj. Niraj, are you online?
Yes, sir.
All right. I'm going to ask you to talk us through a few of these questions. 55-year-old guy presents with abdominal pain to ED. CT scan shows acute uncomplicated diverticulitis without any significant wall thickening. Some IV antibiotics are commenced. The patient improves clinically and is discharged home after 2 nights. Talk me through what are your principles of conservative management. We've covered this, but if you could just recap again.
So case of diverticular disease with uncomplicated diverticulitis, successfully treated or completed management with IV antibiotic. The conservative management treatment is in hospital and then outpatient management. In hospital, you'd want good pain relief, good hydration, and IV and oral with IV antibiotics to get over this period of infection or inflammation.
Yeah, and when you're assessing the patient and you're looking at when to send them home, what are the criteria that you look at and assess about when the patient's right to go home? What factors are you taking into account?
So, number one, the patient factors, the signs and symptoms, vitals was heart rate and temperature, if it's normal, and symptoms of pain or any abdominal pain mostly, with appetite as well.
Yeah, yep, and probably the only other thing on that is then abdominal examination as well. So serial abdominal examination, improving tenderness and resolution of peritonism, other important things. Yep. In terms of what is the role of a colonoscopy in this setting? Who are you going to do a follow-up colonoscopy on to investigate this?
Ideally, I think you would want to have a colonoscope done for everyone with the CT finding of diverticular disease to know the extent and to document where the diverticulosis is present in which segment. So if in a case where they have an emergency presentation, you exactly know where the pathology is.
Yes.
But targeting a more specific population who have severe disease or presentation would be more sort of resource-wise better. So you'd want someone who's probably taken a longer time to settle down with antibiotics, and also the age factor, someone who has more risk factors of diverticular disease.
And so just
alcohol
to clarify, what's the reason you're doing the colonoscopy?
First reason is to confirm the diagnosis and know the exact places where the diverticular disease is present in the colon. And secondly, to also rule out polyps and carcinomas.
Yeah. I think to me that's a more important reason. That's the reason we're doing this, because we know that colonic cancer can mimic diverticular disease. And so the real reason in my head that you're doing the colonoscopy is to exclude a colonic cancer. Okay. If you were to choose, what group of patients with diverticulitis do you think are at higher risk and really need a colonoscopy? Which patients?
Someone who is probably younger, maybe less than 50 years old, who has presented with diverticulitis and confirmed with CT.
Maybe they're probably less likely though to have a cancer. What type of diverticulitis or which type? What do you think is more likely to be a cancer? A uncomplicated or complicated diverticulitis?
I think a complicated one.
Yeah, spot on. Yeah, so complicated, so perforated diverticulitis has a much higher association with being actually being having an underlying malignancy compared to uncomplicated diverticulitis. There's actually very good data from the Western world to say that patients with uncomplicated diverticulitis with a good quality CT scan that has the absence of any significant wall thickening, they are at no higher risk of having a colon cancer than the rest of the population. So there's actually quite good evidence showing that if you've got just uncomplicated disease, you've got no significant wall thickening, then that patient may not need to have a follow-up colonoscopy. Again, most patients in Australia will still get a follow-up colonoscopy, but there is good evidence to show that they're actually at no higher risk of having a colonic cancer than the rest of the population. Okay. And again, if this patient was 85 years old, would you be doing a colonoscopy on them?
The risk for cancers is highly likely in that age group too. So probably yes.
Yeah, I suppose it depends on how good they are as an 85-year-old. Hey, we all know there's good and bad 85-year-olds, so you're going to take that into account as to what their comorbidities and functional status are.
Right.
So conservative management, I think we covered all of this. Symptomatic, hemodynamically stable and medically uncomplicated, either admission or outpatient, oral IV antibiotics. We want to cover gram-negative and anaerobes, which we started at the start. Fluid resuscitation, again, reinitiating of diet under supervision. We give all our patients diet straight away. We don't fast our patients. We go straight to a normal diet. We will just keep patients on some clear fluids for the first 12 hours, maybe, if we're worried that they may need an operation. But certainly the evidence supports that we can give patients diet straight away, we can feed them straight away, that we don't need to fast them. And then we're looking at colonoscopies. So again, there's variable recommendations for colonoscopies about whether or not there's all cases versus uncomplicated. Again, the main reason, as we spoke about, for doing a colonoscopy is because a neoplasia may mimic acute diverticulitis. Okay. Again, a good principle we always think about: if you find a cancer, if you've got an 85-year-old who you wouldn't do a colectomy on, then there's no point doing the colonoscopy to find it in the first place. Again, as we spoke about, uncomplicated disease, the risk of malignancy is about the same as the general population. Why we normally wait 6 weeks here? Paneet, why would you want to wait 6 weeks after an episode of diverticulitis to do the colonoscopy?
Not too sure.
Yep. Any ideas, anyone? Or how soon would you guys normally wait until after an episode of diverticulitis to do the colonoscopy?
I think you're worried about the perforation in the acute setting, so you would want to wait until it settles in and when the inflammation has resolved. Perfect,
spot on, exactly. Yep, you want to, again, patients who have an acutely inflamed colon are at higher risk of perforation. Spot on, Linda, you want to allow that time to resolve. And Joe, we normally say anywhere between 4 to 8 weeks afterwards, ideally 6 weeks afterwards, to allow the resolution of that inflammation to bring the risk of perforation back down to the baseline. This is our final case to discuss. So we have got, who am I going to ask? Anna, can you, I want to ask you a couple of questions about this. So we've got a 49-year-old lady who presents after a 5th episode of diverticulitis. One of those episodes required a percutaneous drain, so it was a complicated episode. The other 4 episodes have occurred over the course of 18 months, but were managed with oral antibiotics. would you recommend an elective resection, Anna, and talk me through the factors that would make you decide for or against?
So complicated diverticulitis is an outpatient treatment for selection for OT for elective surgery. Sorry, I'm not too sure about the patient criteria or the selection criteria for patients for elective surgery, but one of the risk factors after if they have non-successful outpatient treatment would be, can probably offer them elective surgery. She would be considered a high-risk patient because she's had a complicated first attack, so probably put her on the risk. The other patients you'd probably want to offer elective surgery would be anyone else who has immunosuppression.
Yep. So
but,
yeah, immunosuppression.
So those are,
yeah, so immunosuppression, I think, is a good point. Patients who are immunosuppressed, transplant patients who you're worried that are going to get into trouble. That's a good thing. Yep. Next one.
A complicated first attack. Would also recommend elective surgery for one who has had a prior episode of a complicated diverticulitis and abscess or some form of current attacks.
Yeah, that can be a relative indication, but a young person who's presented with a complicated attack, if they're managed conservatively to start with, then yes, you could consider doing elective resection on them. Who else? What other complications would we operate on?
Good bleeding. Those who've had a diverticulitis with bleeding that has not responded to medical therapy, or
so again, that can be not so normally in the elective setting, but certainly you would want to be very sure about where the bleeding was coming from, and you'd want to localize that bleeding, because I mean there could be many diverticulum. If you're just taking out a section of the colon, you'd want to be sure that you knew where that was coming from, and you'd want them to probably have recurrent episodes of bleeding. What other complications can we would we operate on?
Complication, abscesses, perforations. Apart from peritonitis and abscess collection.
Yeah,
the other special groups. Younger patients who've had severe recurrences under the age of 40, would you like to operate on those patients?
Yeah, possibly.
Right-sided diverticulitis? Or?
Not necessarily, no. I think other things that we're going to think about is other complications such as formation of diverticular strictures. So patients who've got symptomatic strictures, they're unlikely to resolve conservatively and will need an operation. And the other thing is fistulous disease. So diverticular fistulae are the other things that sometimes can be operated on. So this is what our list we've made here. So indications for elective surgery. So there's complicated diverticulitis, either the formation of strictures or fistulae. Patients who have episodes of recurrent diverticulitis. Again, do you know what I mean? It's not always, we don't always use this fourth episode or an abscesses thing. It's often, do you know what I mean? These are just rough figures, but patients who have got recurrent symptomatic diverticulitis or what we call smoldering diverticulitis can be indication for an elective resection. I think, as we correctly spoke about before, patients who are immunocompromised or transplant patients, and patients who can't tolerate flare-ups or other things. That is everything for my talk. Have we got any questions or anything that anyone wanted to discuss further?
Yes, sir. Sorry. So the first case scenario, you mentioned that the lady just had the left lower quadrant peritonitis.
Yes.
Now, in a setting like ultrasound scan is not useful. The X-ray is normal, but in the setting of where we don't have any CT scan, and she's not generally peritonitic, so would you opt for operative procedure for that lady straight away, or just give a trial of antibiotics and see how it goes?
Yeah, I think again the thing. Great question, Linda. I think the difficulty in assessing that first case was that it was a retroperitoneal perforation. So I think in that situation that a lot of the normal abdominal signs that you expect from a peritoneal perforation were absent. The patient had a bit of left lower quadrant tenderness, but actually that because this was a retroperitoneal perforation, there was very limited normal abdominal signs that we'd expect to see. So from that setting, I think it would depend on how the patient responded to initial conservative management. So in that situation, again, as we spoke about, we'd be giving intravenous antibiotics and IV fluids, and we want to see if this patient was a responder or not. I think if they responded and quickly got better and we didn't have a CT scan, I think they may be appropriate for a trial of conservative management. But again, if they failed to respond or if they didn't settle with antibiotics, then the patient would end up needing an exploratory laparotomy to see what was going on.
All right, thank you.
Any other questions from anybody?
Yes, sir. Salesi, yeah. Just from this case that we see on the screen,
yes.
If we opened up intraoperatively and we found extensive diverticulum throughout the large bowel, would you be tempted to treat that as well, or just affected ones?
Just the affected disease. Yeah. So I think, again, a great question, Celeste, because we often see that, especially in our Western population, that again, sigmoid colon's the most likely place for diverticulum to form, but often we will see diverticulum throughout the rest of the colon. Certainly that we would only resect the symptomatic or the issue of the colon was causing a problem. So we'd be just doing, in this case, just doing a sigmoid colectomy. She had diverticulum throughout the rest of her colon, but we left them alone. They weren't causing any problem. Just did a sigmoid colectomy, cut out, removed the problem, and then created an colostomy from there. But a very good question.
Thank you. Yeah.
Any other questions?
So, hi there. Sorry, I've just joined. I'm Dr. Delasau. I'm one of the surgeons.
Hello, nice to meet you. I'm Henry.
Henry Bula Vinaka.
Bula.
I apologize. I didn't realize you had a teaching on tonight, so I've just clicked in towards the end of your talk.
Thank you. Welcome.
Thank you. Thank you for teaching us and teaching the registrars tonight. Thank you for your time. I was just going to ask a question in terms of, I know during my training in New Zealand, we've had a few cases where we did on-table lavage for these sort of cases. I know that teaching for exam answers is safety first. Yeah? Doing the safe, kick for touch, Hartmann's procedure is the safe answer for an exam. But in reality, as you probably know, you might have done already, is in certain cases where there's the physiology is good, the patient's factors are good. There's always that option where you can do an on-table washout of the proximal colon, and go for a primary anastomosis and may cover with a covering loop ileostomy.
Yeah,
you may have covered that during your talk.
No, I didn't. We certainly talked about the difference between factors between doing a Hartmann's procedure with an end colostomy versus doing a primary anastomosis with or without a covering loop ileostomy. I think one of the on-table lavage raises a very good point, and certainly the main way that I've seen or been involved in that is doing an on-table lavage where you want to perform a primary anastomosis, but you think the patient's high risk and want to cover them with a loop ileostomy. I think one of the issues is that that we find if you're doing this in the emergency setting, the patient's not going to be prepped. So you're going to have a column of stool that is going to be on the left-hand side. And one of the risks with that is if you do a primary anastomosis, or we find if you do a primary anastomosis and cover them with a loop ileostomy, that column of stool is going to be sitting next to your anastomosis. And if you've got issues with having anastomotic issues, that column of stool will cause significant problems. As opposed to in the elective setting, when you bowel prep the patient and you haven't got that stool. So certainly, as you mentioned, that and for the registrars, that by doing that on-table lavage and getting rid of that column of stool, that allows you to perform a primary anastomosis and then still cover them with a loop ileostomy, but not have that the column of feces that's next to your anastomosis. So no, not something we covered, but a very good point. And always, always an interesting operative discussion talking through those the different possibilities of how to deal with it.
Sure, thank you. How do you do, if you have to do it? How do you do your colonic lavage? Just for interest.
So we've done it different ways. I certainly seen it done through the appendix before. So put a purse string suture around, perform an appendicectomy, and then put a Foley's catheter in, tie it with the purse string suture, and then perform the colonic lavage through and filter through and get feces out through the end of the colon. That's the most common way that I've seen it done. Otherwise, I've also seen it done retrograde through the colon, where we flush the colon backwards and then also manually milk it out. It always ends up than what you think.
It can be, what I've seen, what we've done in one of the hospitals I've worked in, as you said, using the appendix.
Yes.
And tying a tube, the anesthetic tube, the ET tube.
Yes.
At the end of the distal colon. So tying that and then draining that out onto the side of the patient onto a big basin on the floor.
Yeah, nice. Okay.
And running saline through the, as you said, using a Foley through the appendix orifice.
Yes.
Seems to work reasonably well. Yeah, otherwise it could be quite messy washing the colon. Yeah.
Indeed. Indeed.
Thanks. Thank you very much. Thanks. Appreciate your time.
Excellent comment. Any other questions or comments of anybody? No. All right. I think that that concludes our teaching then. Thanks everyone for coming along. Thanks again for Parneet for organising and coordinating the session, and I look forward to doing another session with everyone again in a couple of months' time.
Thank you.
Thank you very much. Thank you.
Thank you, sir.
Have a great night, everyone. Bye.
Naka.
Okay.
Sleeping, Dr. Praneet.
No, boss, not sleeping.
Showing his muscles there.
Hey. That's your fifth.
He's lying down in prone position.
Yeah.
Hey, how's the back, Pinoy? How's the back?
It's good, boss.
Yeah.
Yeah. Pains mostly gone now.
Oh, very good. Very good.
There's some neurological deficit.
Nearby any changes are just.
Did you see Dr. Sonam? Is Dr. Sonam online or?
Yes, I think so. No, I think she's in ED.
Dr. Sonam was saying that one of the patients in ED was not very not very comfortable having a PR exam.
Yeah.
Yesterday, so I was saying, not everyone likes a PR exam. It's one of the reasons why patients don't come in, because of that rectal exam.
Yeah. Also saw her saying bright anal tone.
Hey, Dr. Delasau.
Yeah.
Boss, just going back to that on-table lavage that you were talking about.
Yeah.
Sometimes with this class 3 or category 3 or 4, if we use Hinchi classification and we go in with that sigmoid perf, sometimes there can be a concomitant inflammatory bowel disease present. Or and that cannot be excluded without a colonoscopy. Would you still consider doing that?
No, way. I mean, the exam answer.
You've muted your.
Sorry, Ray.
Somebody touching your mic, boss.
A small hand. Take your phone out of your pocket, boss.
Sorry. Keep mute. Just mute by itself, Ray. I think when it hears extra sounds, it mutes automatically. What I was saying to what's your friend's name, Binoy? Stephen.
Henry.
What's that? Henry, eh?
Yeah.
The exam answer is safety first, eh? Safety first. You always do a Hartman's. That's your exam answer. But never be shy to say, there is evidence based. You always have to say that based on the patient's physiology. You always say that. You'll never say I'll do a primary anastomosis. You'll say the safety thing here is to do a Hartman's procedure. But there are studies and there are evidence stating that there's a role for primary anastomosis with a covering loop ileostomy based on this, and this. So you always have to check the patient's physiology, the Hinchi's classification, obviously the amount of contamination, patient's factors come into that as well. You just mentioned that. It just shows that you reading, you are aware there are options. Anyone can do a Hartman's, but as you know, in our Fijian setting, you say that the stoma is a big issue in our culture, having a bag. So you always have the back of your mind, is there a chance I could join this? But I'm aware there's a risk associated to this, doing a primary anastomosis. And there's been some role of doing an on-table lavage, where you wash out the colon to remove the residual fecal material, do a primary anastomosis, and I will cover with a loop ileostomy. That's been done, that has been done, and it's been shown that it works as long as you do a colonic lavage, using the technique that he was describing. But if there's any uncertainty, obviously uncertainty about the case, the safety answer is Hartman's procedure. Right. You can always do a colonoscopy afterwards and then do a later reversal of your Hartman's.
And drains boss when you do that.
The evidence is not there, right? But it doesn't hurt to always put a drain in the pelvis.
Okay.
Always put a drain in the pelvis. You say the indication for this, there's the evidence is not strong, but you always put it down there in case there is there's always pelvic residual collection, Right. You always remove that 2-3 days after surgery. And if you're doing a Hartman's, don't forget to say you'll put in a flatus tube, a rectal tube. A rectal tube, there is evidence because of, you've got a sphincter and you've got a stump. Right. So the risk of a stump blowout drops. It reduces with a flatus tube, which you leave it in for 3-4 days, and you remove it after 3 or 4 days. Just to reduce that the risk of stump blowout.
Okay.
I was while we were on that case, that case of Law and Chochi, the right hemi that they did, I put up the histology. I think